Ladies and gentlemen, apart from welcoming the wonderful couple from Birmingham and a wonderful gentleman from Dr. Podar's MBBS days, Dr. Doval. All of you know Ajit Doval. So, Mr. Dr. Doval, yes. And I request Dr. S Sengupta to take the forum and I welcome you to CME number 880. 880.
Thank you, sir. As everybody knows, my only recognition out here is as a student. And one thing that I realize is that as and when I am ordered to chair a session or speak at a forum out here, the felicitation gifts in my name keep going down in number. Right now I am only saddled with the plant. Thank you very much. So, thank you everyone, and we will be having a discussion on cardiology today. And in the field of medicine, there's when we consider cardiology, technology and technological advancements in no other field of medicine has it affected so much as in the field of cardiology, which has been associated with hugely improved qualities, which is quality associated life years for the patients. There has been tremendous advancements in technology with respect to interventions in terms of backups. And right now, the buzzword is in physiological spacing of his pacing, etc., which would be taken up in the due course of time. And though technology also comes with its fair share of pitfalls, and one has to stratify patients and also look for complications as and when they arise. But suffice it to say, the amount of advancement in technology as support to basic clinical cardiology has been huge in the last 3 to 4 decades and is constantly evolving. And it has hugely impacted patient lives, and we all know that it has directly involved, increment in longevity of the patients and quality of the life of the patients. So today we are going to have 3 talks from the very capable Department of Cardiology from Holy Family Hospital, which is now superbly headed by Dr. Amitabh Yaduvanshi. We know that Dr. Amitabh Yaduvanshi has started off with this department with Professor Mohan Nair, as was mentioned out by Dr. Chauhan. Now Dr. Amitabh is heading this, and we will be having 3 talks. The first one would be on the introduction to certain cardiac arrests, role of physicians in early detection and prevention, and it would be discussed by Dr. Mohit Bhagwati, who has already been introduced to you. So he is in charge of acute cardiac care and a consultant cardiologist at the Holy Family Hospital. And he has been awarded with the M.K. Ganguly Award for Young Scientists in Clinical Cardiology 2019 at the ISHR 2019 Annual Conference. And he has been a runner-up at the SCAI A.V. Gandhi Award for Excellence in Cardiology 2020, as well as the Resident of the Year 2019 at the Max Institute of Medical Excellence. So, may I ask Dr. Mohit Bhagwati to do his presentation, and I would request all the 3 speakers in sequence to stick to the time schedule of approximately 15 minutes so that we can follow it up with some fruitful discussion. So thank you.
Yeah, good evening everyone. Am I audible? Yeah, good evening everyone. For such a lovely experience today, and it's an honor and privilege to address this 880th CME, which is a marathon and miraculous job by Physician Forum of India. I must congratulate you guys. So today we'll be speaking on sudden cardiac arrest, and the best thing which I saw here after opening your members directory was that there was a very beautiful article on how to do a proper cardiopulmonary resuscitation. So nothing gives me a lead to start my talk. So sudden cardiac arrest, this audience does not need any introduction on cardiac arrest. But just for the sake of completion, it is an abrupt cessation of normal circulation of blood due to failure of the pumping capacity or pumping capability of the heart. When the pump stops to function, the blood stops to flow and patient has cardiac arrest. So these patients, they suddenly die. We just lose them in a couple of minutes or maybe 4 or 5 minutes. So as you know, that we are reading all these news in our time. We have lost our ex-president, President Kalam, then Jagmohan Dalmia, then many celebrities, maybe Siddharth Shukla or K.K. Singer, and just to mention, as Professor Nair was also discussed, our mentor, our previous head of the department, he lost even him to sudden cardiac death. So Puneet Rajkumar, a very famous movie star. So we are seeing it more often than before, and we are seeing it around us. We are getting videos on our mobile phones and WhatsApps and Twitter and Facebooks. So it is all around. The first thing which I want to put here is that every sudden cardiac arrest is not a heart attack. So we might say that heart attack is one of the most important and the most common cause of sudden cardiac arrest. But heart attack is just when your heart is not getting enough blood supply because of the blockage in coronary arteries. And sudden cardiac arrest is when the electrical activity of the heart goes boom. Either it stops contracting or it contracts like it runs like a horse. You have a tachycardia, be it VT or VF. So as you can see in the diagram, almost 90% of the sudden cardiac deaths are because of arrhythmia. And among arrhythmia, almost always, more than majority of them, 60% of the cases, it is monomorphic VT, and 15% of the cases, it is polymorphic VT. So it is ventricular tachycardia which is killing you in seconds. You're standing, you're dancing, you're doing your job and you suddenly go. So it is ventricular tachycardia almost in 3/4 of the cases which is the cause you have a sudden cardiac death. So the patient suddenly collapses, he stops breathing, there is no pulse, there is no BP, what to do? So what to do is do a CPR and effective CPR, call for ambulance, shift the patient to the nearest cardiac center, and then you can maybe see what can next be done. Whereas MI gives you a little time. A patient of myocardial infarction dies either due to sudden cardiac arrhythmia or due to prolonged hypotension or shock, as you better know it. But MI still gives you time to go to the hospital, get yourself treated, get a primary angioplasty or a thrombolysis done depending on the setting, and you stay to live on. But sudden cardiac arrest does not give you any time. It's a silent epidemic. We know, we are looking at it every day. Even in India, the graph is just going and going up, and everybody is dying because of sudden cardiac arrest all around us. However, when it comes to etiologies, we have already discussed, although heart attack is different from sudden cardiac death, it is heart attacks which mostly result into a LV dysfunction and finally a sudden cardiac death. So what to do? So apart from medical therapy, we have now this device available for many years which is known as implantable cardioverter and defibrillator. It's a small pacemaker like matchbox size device which is implanted here below the clavicle under the skin with a wire and a lead going inside your heart and a coil which can just give a shock like we give a DC shock externally. And regarding trials, so now we have plenty of evidence that once a patient has survived a sudden cardiac arrest, you give him medicine and then compare to medicine plus implantable defibrillator. Whether you see American data, you see European data, you see Canadian data, you see Indian data, every data says that you have to give this patient AICD for the secondary prevention of sudden cardiac arrest. And when compared to medical therapy, the benefit is really evident in favor of ICD. So if you receive a patient who had experienced a cardiac arrest, had a CPR done, then you have to give them ICD. And if the LV dysfunction is also there, then you have to give them ICD. This brings us to the second topic. I will try to go as fast as possible and not keep you away from the food. Second is in patients who had myocardial infarction and now they are moving around with a low EF. So apart from pump failure, which is shortness of breath, going into pulmonary edema, they are at risk of sudden cardiac death because they have a substrate. The substrate the scar because of myocardial infarction, which can misfire. And the moment it misfires, patients die. So people who have had MI, they have a sudden cardiac death risk almost 6 times, 4 to 6 times more than people who do not have MI. So I'm sure you must have already seen patients who have history of myocardial infarction. Please look at their LV ejection fractions. If it is low, offer them ICD. Send them to a cardiologist who can put an ICD. And patients who have LV dysfunction post-MI, they are at great risk. So they can even die, like 50% at 5 years is what the mortality data is. And most of them who are appearing healthy, who do not have pump failure, they die more often with this sudden cardiac death. So patients who are in now New York Heart Association classification 4, they do not die of sudden cardiac death. I mean they do, but the chances of dying due to pump failure are more. But apparently healthy looking patients who have this LVEF of 40%, 35%, have history of a large MI, they can die. So you have to send them for an AICD. There is a lot of data whether you have MADIT, MUS, MADIT 2, SCD, HEF. All of them say that if you had MI, you've got your Vikas done, you wait for 40 days, do an echo. If the echo is showing EF of 35% or less, give them ICD. It's a class 1 indication with a level of evidence A. If your patient does not have MI, he's just some cardiomyopathy, and the ejection fraction is again in the ballpark of 35 to 40%, you still have to give them AICD. Although the chances of sudden cardiac death in these patients are low, but it is not zero. So I would like to simplify it. The patient had a history of sudden cardiac arrest, SCS survival, you have to give them ICD irrespective. The only subset I would say that you will not give them ICD when they have a sudden cardiac arrest or a VT because of ongoing MI which has been treated, and you wait for 40-45 days and the LV function is normal. Only these patients do not require AICD, and they are a very, very minority. So for majority, if you have sudden cardiac arrest survival, you get an ICD. And for primary prevention, if you have heart failure, you are NYHA class 2, 3, 4 ambulatory, you are on medicines, and your LVEF continues to be less than 40%. Apart from guideline-directed medical therapy, you get one ICD. And regarding non-ischemic cardiomyopathy, of course, for general, basic, easy understanding, they have to be given ICD if the EF is less than or equal to 35%. So this is the decision chart which we use at Holy Family Hospital. I would like to request you to also see whether a patient has some ischemic heart disease with a meaningful survival of more than 1 year expected. You just have to tick the boxes. If the LVEF is low, 40 days have passed, NYHA class 2, 3, EF is 35%, give them ICD for primary prevention. Or if there is history of some current cardiac arrest, hemodynamically unstable VT, or a stable VT on Holter, give them ICD for secondary prevention. And I would like to conclude, and I would like to take a little time on this particular slide, that the highest clinical risk factor for SCDR, again, low EF. So we are looking at echo reports, left, right and center, the ejection fraction is less than 40%. Just look very carefully at patient is saying, no, I am not breathless, it's okay. But you have to explain the patient that, boss, you can die because your heart is a substrate which can misfire. If your patient had a history of MI and now have a residual LV dysfunction, the patient can die. You have to explain it to them. Or if there is a patient has DCMP because of ischemia or non-ischemia, they are on guideline-directed medical therapy, their EF continues to be low, or even if the EF is not very low, but they had runs of VT or SVT on Holter, like VT, sustained VT or non-sustained VT on Holter, then you have to give them ICD. And certain genetic disorders, especially hypertrophic cardiomyopathy, these patients are to be studied in great detail and risk stratified whether they require an ICD or not. And of course, arrhythmia, I know everybody understands long QT syndrome, ARPD, Brugada, you have to give them ICD. So I would like to conclude my presentation. Thank you very much. Very good. And we are working at Holy Family Hospital, which is nearby, a 75-year-old hospital, and your your patients who require ICD in today's era, because these therapies are also very costly. So at Holy Family Hospital, the hospital has made sure that the cost of the device remains the lowest in the city. Thank you very much. Any questions, please?
We'll take the questions at the end of all the 3 lectures. Can I ask you to join me at the dais out here? So we go on to the second lecture, which will be by Dr. Vikas Kataria. He will be speaking on physiological spacing. Is it already the mainstream? So, briefly introducing Dr. Vikas Kataria. He is the head of arrhythmia services and senior consultant cardiologist at the Holy Family Hospital and has an experience of more than 17 years in the field of interventional cardiology. We have interacted on a personal basis at Max also when he used to be there, and he has a rich experience of performing various interventional cardiology, cardiac electrophysiology and device implementation, implantation and implementation procedures. Over to Dr. Vikas Kataria. Thank you.
Thank you, Dr. Sengupta, for those kind words. Thank you, Judicial Board of India, dear colleagues and friends, for giving us this opportunity. So I'm going to speak on conduction system pacing. So conduction system pacing is basically a new technique of implanting a pacemaker, especially the ventricular lead of the pacemaker. Till now, majority of the pacemakers, almost all of the pacemakers, the ventricular lead we implant at the apex of right ventricle. But here, the tip of the lead is implanted directly over the conduction system. So as we go along, we will come to know how is it done and what are the advantages of conduction system pacing. So my job would be to keep it simple, less boring and interesting for all of us. So before we go into the detail of conduction system pacing, so let us just brush up our knowledge about the conduction system. The electrical impulse of the heart is generated here in the sinoatrial node, SC node we all know, which is at the junction of SVT and right atrium. And once after this, the impulse travels down through the atrium and reaches the AV node. And from AV node, the AV node is slow conducting part of the conduction system, and once it crosses AV node, it travels very fast down the rest of the conduction system, which we call the His-Purkinje system. After the AV node is the His bundle, and this His bundle then divides into right and left bundle. The left bundle again divides into anterior and posterior fascicles. So once the electrical impulse crosses this part, it travels very fast, within milliseconds it depolarizes both the ventricles. So because the conduction is very fast and both the ventricles are depolarized within fraction of milliseconds, so we get a very narrow QRS of the surface ECG. So the narrowness tells us that the conduction system is healthy and both the ventricles are getting depolarized within few milliseconds. On the other hand, when we implant a pacemaker, in majority of the cases, this ventricular lead goes till the tip of the right ventricle, which is the apex of the right ventricle. And when the electrical impulse from this pacemaker goes here, it first depolarizes the surrounding myocardium, the muscle. And muscle, we know, is a slow conducting tissue. So the electrical impulse travels slowly from right ventricular apex to the interventricular septum and then travels slowly towards the free wall of the left ventricle. So this whole conduction, the whole depolarization or electrical impulse travels at 1/10 of the speed of His-Purkinje system. And because it's very slow, so what we get on the ECG is this is the pacemaker related ECG, and you see a broad QRS. Because the conduction is very slow, the time taken is longer, so we get a broad QRS on the ECG. So we'll come to know in our later portion of this presentation that this broad QRS and slow conduction has its own harmful effects. So let us see this harmful effects with the help of a case. A 68-year-old gentleman who presented to our hospital with recurrent syncope, 3 episodes over a span of last 2 weeks. And in all these episodes, he used to lose his consciousness for a fraction of seconds to become completely alright after that. So we did some workup on this patient. The ECG was completely normal, echo was normal, ejection fraction was normal. We knew that this is not neurological, but still we completed the neurological workup of loss of consciousness. The MRI, EEG, everything came out to be normal. But because we had a strong suspicion of arrhythmic syncope, so we put the patient on extended Holter monitor. Holter, we know, is a extended ECG, a device which can record the ECG for 24-48 hours, and this extended Holter kept recording the patient's ECG for 7 days. Now at our center we have few more devices which can record up to 2 to 3 years. We call them ILR, and Dr. Amitabh is going to speak on those devices. So this extended Holter is attached to the patient. But first day and second day and third day, patient was completely alright. There was no changes in the ECG. On the fourth day, again patient started experiencing the same symptom of pre-syncope and syncope. And at that time, we noticed multiple episodes of 2:1 AV blocks. As you can see, here each P wave is followed by a QRS. This is a normal conduction, but here these P wave are not followed by QRS. This P wave is not cured. So this is multiple episodes of 2:1 AV block. So these were the reasons of his syncope. So now we have a diagnosis. Patient is suffering from significant high degree AV block, and what he requires is a pacemaker. So patient was implanted with a pacemaker. This is a dual chamber pacemaker. This is a conventional form of pacemaker. The upper lead is in the right atrial appendage. This places the atrium, and the lower lead is at the apex of the right ventricle. So this is the conventional way of doing the pacemaker. So we did the same way. It was almost 2 or 3 years ago. So after this was the ECG. So you can see this, every period now is being followed by a QRS. So patient is not going to have that syncope because the ventricular rate is well within the normal range. So patient was asymptomatic, the procedure went fine, we discharged the patient on third day. We kept following him up in the OPD. Patient was syncope free, no problem. The pacemaker interrogation every time was within normal level. So almost 1 year passed, and then the patient one day came to us with a history of breathing difficulty, dyspnea, for almost 3 months. So because he's now 70, diabetic, hypertensive, so we wanted to rule out the coronary artery disease and other causes of dyspnea. So the ECG was completely pacemaker dependent, so ventricular phase rhythm. To our surprise, this time the echo showed global hypokinesia, ejection fraction dropped down to 30%. So remember the initial ECG last year when he was admitted for pacemaker implantation was completely normal. Now it has dropped down for 60% to 30%. Antiprobian was elevated, so patient was clearly in heart failure. Pacemaker was working fine, all the parameters were normal, but now patient was 90% dependent on the pacemaker, which means almost 90% of QRS lost because of pacemaker. So this was the echo. Just to echo. See. So yeah. So you can see this. Ideally, both the opposite walls of left ventricle should come together and squeeze the blood. Here, the muscle is hardly contracting, so it is a form of severe LV dysfunction. We did the angiogram because we wanted to rule out obstructive disease in the coronary arteries. So the angiogram, left and right system were completely normal. We did a cardiac MR to rule out any other cause of left ventricular dysfunction. Cardiac MR also did not help. So we came to a diagnosis that this patient is suffering from a disease from an entity which is called pacing-induced or pacemaker-induced cardiomyopathy. So pacemaker-induced cardiomyopathy is left ventricular dysfunction which occurs after the implantation of permanent pacemaker. A drop in ejection fraction of 10% or more after the implantation of right ventricular pacemaker. So, provided you have ruled out all other causes. So, if you don't find any cause of LV dysfunction after pacemaker implantation, then most likely the patient is suffering from what is called a pacemaker-induced cardiomyopathy. So, why this happens? Nobody knows, but most likely the most probable hypothesis is, as we discussed earlier, the cardiac impulse is delivered at the right ventricular apex, and from here it travels slowly. First, the ventricular septum is depolarized, and after a few milliseconds, the opposite wall, free wall, is depolarized. So, in a way, we are actually creating a dysynchrony. Both the walls are not contracting simultaneously, but one after the other. They are out of sync. So, this dysynchrony, when it lasts for a few months or so, then cellular changes happen in the muscle, which result in permanent dysfunction of the muscular function. Not all patients develop pacing-induced cardiomyopathy. It is seen in approximately 20% of patients with permanent pacemaker, and that too who require at least 20% pacing. So those patients who require pacemaker occasionally, they generally don't develop. Patients who are elderly, males, the baseline QRS is 5. Baseline ejection fraction is low, and history of AF. These are the patients who are likely to get pacemaker-induced cardiomyopathy. After the pacemaker, if the pacemaker, the QRS is broad, then the chances are higher. If patient requires more of ventricular pacing, then the chances are higher. So if the patient is completely dependent on pacemaker, the chances are higher of developing pacing-induced cardiomyopathy. How do we treat it? How do we treat it? Of course, we have to start the heart failure medicine, the 4 pillars of heart failure. As far as devices are concerned, one lead you already have placed here at the right ventricular apex. You can put the another ventricular lead at the free wall of left ventricle. So you have 2 leads pacing simultaneously. As a result, both the opposite wall they contract simultaneously, and the dysynchrony is gone. So the pacing-induced cardiomyopathy will gradually improve. So this is what we do in a CRT or biventricular pacing. See, relatively new technique which is the topic of the day is conduction system pacing. So in conduction system pacing, we do not put the ventricular lead there. Instead, we put this ventricular lead directly either on the his bundle or on the left bundle. So because the lead is placed directly on the conduction system, so the electrical impulse uses this conduction system, travels down very fast, and both the sides of ventricle, they are depolarized within fraction of milliseconds. So there is no dysynchrony, and the patient does not have this LV dysfunction, left ventricular dysfunction. What is this? So coming back to our case, so we chose to remove the previous ventricular lead. So the lead was here, we removed the lead, and instead we put a new lead. This yellow portion I have made it basically to show that this is the interventricular septum, and the lead is going deep inside the septum, almost stopping just before left ventricle. So we are directly hitting the left bundle branch. So this is the AP view, the chest X-ray of the same patient. This is AP view. This is the right atrial lead. The ventricular lead conventionally is placed here at the apex, but instead we have put it deep into the septum at the left bundle. So let me overlap the conduction system. So you can see the tip is touching the left bundle directly. So now the impulse will travel down this conduction system, which is a faster conducting tissue. So dysynchrony is gone. So now you see the QRS is very, very narrow. This is a pacemaker driven ECG. So we cannot even find that this is a pacemaker. You can't believe that this is a pacemaker dependent patient. So earlier the ECG was this. So you can see this is almost 4 to 5 very small squares of hair. So which means around 160 milliseconds of QRS. And now this is almost 2 to 3 small skids, approximately 80 to 90 milliseconds of QRS. So the results are much better than a conventional pacing technique. So after this, this is the next one and this is the next day. So I don't know whether you will be able to appreciate, if you look carefully, this wall and this wall, they are contracting out of sync. They're not contracting together. Whereas after the pacemaker, both these opposite walls are coming together in the same phase of time. Synchronized. So patient was discharged after the conduction system pacing. It has, after we kept following him up in the OPD. After 6 months, patient was completely asymptomatic. We could stop diuretics and heart failure medicine, and the left ventricular ejection fraction improved back to normal. So now there is enough data. We are for almost, this left bundle pacing has been there for almost 5 years now. We have multiple abundant data with not even for sinus node dysfunction, airway dysfunction, even for CRT indication. Now we have data that the conduction system pacing is almost going to replace the conventional way of implanting a pacemaker. So this is one of our articles in American College of Cardiology. We were actually a part of a worldwide survey of conduction system pacing. Our center was almost, I think, 1 or 2 centers were invited from our country, and our centers was one of them, one of the participating center here. So now conduction system pacing has completely changed our practice. Now the default mode of putting a pacemaker is conduction system pacing. We have done multiple cases now over the last 3 to 4 years with 100% procedural success. The QRS narrowing could be achieved in almost 95% of patients. And the indications which we do is sinus node dysfunction, AV node dysfunction, and now those patients who cannot afford a biventricular pacemaker CRT, that too we treat with conduction systems. Thank you.
Thank you, Dr. Vikas. Can you just join me out here in the dais? We have had 2 excellent presentations till now. We go over to the final presentation by Dr. Amitabh. He will be speaking on an era of Bluetooth and remote monitoring. So, Dr. Amitabh is a distinguished international cardiologist who has done his graduation and post-graduation from Al-Azhar, and presently is the Director Cardiology at Holy Family Hospital. And he possesses extensive knowledge in interventional cardiology, electrophysiology and device implantation. And his passion for staying at the forefront of medical technology is evident in his proficiency with cutting-edge interventions like leadless pacemakers, percutaneous mitral valve repair, intravascular lithotripsy, orbital atherectomy, and zero contrast angioplasty. So may I ask Dr. Amitabh to do his presentation, and we'll take a question at the end. Thank you.
Thank you, Dr. Sengupta, for a kind introduction, and thank you, Division from India, to allow us to present our cases in our discussion here. So, moving on to once we, Dr. Vikas said, once you have put a conduction system pacing, so what are the other things that have come up into device therapy? So, one thing that is now being talked about quite significantly is remote monitoring. So what exactly is remote monitoring? We all know that healthcare is now moving closer to the patient. Earlier, patient had to go to the lab to get the test done. Now all these things are available at home. There are gadgets and devices that are available to us where you can get a blood sugars done, blood pressure done, SpO2 meters. COVID has taught us that something that can be done at home also. This is one good thing that we got from COVID, that people are more aware of these gadgets, and most of the patients do have a VP operators, SpO2 probe and other things at their home. Then there are certain devices that are available which can actually allow you to get a ECG at your home. There are Apple watches which can give you ECG, and there are various other advancements, technological advancements that are coming up. So smartphone, as we all know, smartphone is a ubiquitous commodity. Each and every one of us have a smartphone, and the penetration of smartphone is much more than any other device available in history. So even penetration is much more even in rural areas, which can then be exploited to generate a lot of medical aspects like education, diagnosis, medical adherence, symptom and environmental data collection and other things. You have now various apps and devices, apps that are available where you can have remote monitoring of the BP, pulse. There are so many companies that have come up with their own apps which you can use. So mobile health or M-health is something that is going up, and it would be an integral part of our life. And so with these advancements in mobile technology and the IT technology, there are certain things that have come up which are helpful for us. So I will not go into so many details. There is a connected system of what is called as Internet of Medical Things. So you can have devices which automatically talk to each other, and they can generate data and send the data to the servers where it can be analyzed. So the challenge that we have is as many patients are now getting these devices put in their body, and once the device is put, that is not the end of your job. It is the monitoring of the devices that are also very important, and sometimes it is difficult for the patients to actually reach the hospitals to get these devices checked. So there is something what is called as remote monitoring, where you can have a device that is connected to a remote monitor, and the patient need not come to the hospital to get his device checked. We can always get the data from the patient's device automatically. So this reduces emergency department or urgent in-office visits of the patient, and it takes a lot of burden off the clinician's time. So this is now, remote monitoring is now a class 1 recommendation for patients who can afford or where this facility is available. But it is not just the facility in the device, it is also the whole ecosystem that should be available to us, so that if the patient has a remote monitoring device inside, the data has to be collected and then collated and automatically sent to the clinicians if required. So remote monitoring reduces patient risk. It has been found that there was a 50% reduction in risk of all-cause mortality in ICD patients who have remote monitoring, and 27% reduction over 3 years. And there was a 36% reduction in hospitalization and 66% reduction in hospitalization for AF or stroke. So all these things suggest that patients who have had more adherent to their follow-up, there is a reduction in all-cause mortality, there is a reduction in lower risk of patient with ICD, and even in pacemaker patient there is a lower risk of mortality. So it's not just the ICD patients who require remote monitoring, even the pacemaker patients who are relatively at a lower risk, they also benefit if you have remote monitoring available to us. So earlier what happened was you had various devices that needs to be purchased separately by the patient, and these devices they need to be charged separately. They need to be near the patient. The patient had to these devices had to be at the bedside, and there were specific times when the data was sent to the servers. Now the Bluetooth enabled smartphone system has now eliminated these middlemen. So you have a device which is Bluetooth enabled. It connects to the app that is there residing on your mobile phone, on your smartphone, and that sends the data to the server that is available in the cloud. So it causes better compliance and better connectivity. So sometimes what happens is patient might be traveling, patient might be going out of city. So he need not carry all this paraphernalia with him. A mobile phone is always available with the patient. So the patient and the mobile phone is always connected to each other. Internet network is always available to the patient through the mobile, and any data that requires urgent transmission is done. So as we showed that with the earlier devices, the efficiency of this was very low. However, with Bluetooth it is improved. So how it is done? So there can be a non-continuous monitoring where the data is sent intermittently. There can be a wireless or alert-based monitoring. So it all can be programmed according to the need of the patient. So this is how you have the Bluetooth. It has a wireless technology. As I mentioned earlier, the device is full-fledged. Everything is available in the device. You just need to download an app and connect the device with the app, which the 20 people do. And the Bluetooth that is used in this device are low energy technology, so it does not really add up to any battery consumption in these patients. So there was a fear in the patients, in the people's mind, that since you are adding Bluetooth to the device, the battery life of the device might decrease. But with the advancement of technology, we all know that so many things are there where Bluetooth is available, and it is a very low energy technology that is used. So the battery usage is not significantly affected by the fact that you have a Bluetooth monitoring that is available. So when they did a feedback of this type of a technology, they found that 99% of patients was satisfied with the use of the mobile app. 98% thought that the mobile app was easy to integrate. 97% thought that they did not disrupt the daily activity because the patient actually does not have to do anything special. It is automatically programmed into the device. And 95% of patients thought that the messages that received through the handling system was useful for them. 94% thought that since they have this ability in their mobile phone to check their status of the device, they felt more confidence in using the device, and 94% did not have any issues with the communication through the app. So even in India, as we all know that the frequency or use of mobile apps are increasing, and even in India the patient satisfaction rate is quite significant, and almost 59% had most satisfaction and 41% had score of 4, which is like almost satisfied.
Very good.
So this is how it goes. We can have a monthly transmission or patient-initiated transmission of alert triggers. So we can set what are the triggers that are high risk, where you need the information to go immediately to the server. Otherwise, scheduled transmission are done. So the clinician has this type of a chart with them, or this type of a dashboard with them, and every patient is then analyzed, and these green things, that means the AI system in the modeling system, they themselves analyze this thing. So if it is a green line, that means the clinician do not need to really bother about these transmissions. They are all standard transmissions. However, if there is any alert, it is given to the patient, it is given to the physician. Patient themselves can initiate, and if there is an alert indication, these patients can be then immediately responded to. So I'll just go to a clinical example. So this patient, 50-year-old female, ischemic cardiomyopathy, LVVB, QRS duration 155 milliseconds, severe LV dysfunction, was implanted on a CRT device with the remote monitoring active. This patient had initially a very good response. 99% biventricular pacing was noted. However, on follow-up after 1 month, the patient said that the symptom improvement that they experienced initially was not as good. And the remote monitoring showed that the biventricular pacing rate has decreased to only 16%. Atrial sense rhythm was less than 1 volt. And when subsequently this patient was taken up, got to the hospital and the fluoroscopy was done, you can see that the left ventricular lead has displaced, the right atrial lead has also displaced. So this patient was then, the lead was repositioned, and then on follow-up we could see that the ACEs, biventricular pacing has improved. So this is one patient where if the patient was called after 3 months as a routine follow-up, for 2 months, 3 months, this patient would not have benefited from the biventricular pacing. So I will not go further into, there are so many examples. So the idea was just to say that with advancement of technology, we have devices that are now possible to be remotely analyzed, and Bluetooth devices that are available with the company, they are very high-end devices, and although they are a bit costlier than the routine devices, but as far as if you see some patients who are coming from remote areas, maybe patients who are residing in Delhi NCR may not benefit that much because they can always come to the hospital. But there are patients who come from far out places who are not very convenient for them to come to the hospital. There might be elderly patients who have mobility issues where it will not be possible for them to come routinely for checkups every 3 months. These patients would definitely benefit from remote monitoring technologies. So with that we end this, and I'll just take 5 minutes of yours to present some of, sir, with your permission, just 5 minutes. So,
with Dr. John's permission.
Yeah, we have time.
So basically the idea of doing this CME was to reintroduce our team to the forum, because we have had earlier interactions with Dr. Chauhan in the group, but then it was few years back, it was actually before Corona times, and things have changed, and now Holy Family Hospital is now also leading into a situation where they are also expanding, they are also now in a different mind frame. So this building that you see is the new super specialty block that is coming up at Holy Family Hospital. It is a 12-storied building that will be coming up. It will be adding 150 beds to the hospital. Total beds of capacity will become 500 hospital beds. So this is our team. We now have a full spectrum of cardiology and cardiovascular surgery available to us. We have Dr. Nitin Gupta, who is our cardiothoracic surgeon. Dr. Vikas, Dr. Mohit and myself are the cardiologists that are there. We have a dedicated non-invasive cardiology person, Dr. Bharat Bansal, and we have associate consultants that are helping us out in the clinical work in cardiology. We have a 24/7 primary angioplasty program. We do all kinds of complex and coronary interventions, ped, left main, bifurcation, CTOs, graft angioplasties, rotational atherectomy and lithotripsy. We are proud that we are among the few centers that do what is called as zero contrast angioplasty, and we have been proctoring other centers for this also. So basically, in patients who have renal failure or whose creatinine levels are high, where you are really afraid that the patient may go into renal shutdown because of the dye, we have used technologies to do what is called as ultra low contrast or zero contrast angioplasty. We do peripheral and carotid angioplasties. As far as electrophysiology is concerned, Dr. Vikas is heading the electrophysiology department. We do radiofrequency ablations of all kinds of arrhythmias. Device implantation, we all do all kinds of device implantations. Structural heart disease interventions, we do left atrial appendage closures, device closures like ASD, VSD, PDA. We also do some vascular interventions like embolization therapy, bronchial artery embolization for hemoptysis, mesenteric vessel embolization for GI bleed, uterine and artery embolization for postpartum, peripartum hemorrhage, hemorrhagization before surgery, and we do also something which is again something that is not done at many centers. We do mechanical thrombectomy for patients with acute pulmonary embolism, and we use the latest devices, which is the Penumbra device, and we have saved a lot many patients with acute pulmonary embolism using this technology, because some of them, they had recent surgeries and so they were not eligible for thrombolysis. Then other interventions that we do is IVC filter placement. Renal denervation is something that we have started for resistant hypertension. ECMO and other things we have been doing for quite some time. I would just go into some data which you can see. Complex interventions, 70% of our interventions are complex interventions. Almost 1/4 of our patients we do intravascular imaging during our complex interventions, and 3D mapping, lot CRT, CRTD. Dr. Vikas and I have been even proctoring other centers for this type of advanced pacing implantations, deep depth pacemakers, ILRs, mitral valve, transcatheter, what is called as mitral clip. So we had experience with one patient which was successfully done with the mitral clip intervention, and we have a dedicated non-invasive lab, two non-invasive labs, state-of-the-art cath lab, and that's the thing. We are also good in academics. We conduct regular workshops, and future super specialty building I have already mentioned is coming up, and we plan to expand our pediatric intervention program. So my humble request to all of you is that since we are I would not say we are the new kids on the block, but we are now trying to take our steps into a bigger field. So our request to all of you is to support us, and one commitment that Dr. Mohit also told you is Holy Family Hospital, as far as the finances are concerned or the economy to the patient is concerned, Holy Family Hospital is better than any other private hospital in the region, because we do not believe in profiteering. We believe that patients should get an economical treatment and best hospital. By economical treatment, we don't mean to say treatment that is substandard. Proper treatment at an economical. Thank you.
Thank you, Dr. Amitabh. I ask you to join me out there. So, dear friends, we have had 3 very fascinating lectures, and which has shown the true impact of technology also in the present field of cardiology, and it's excellent to see how Holy Family is living up to it, and as Dr. Amitabh has mentioned, they are doing almost all the procedures at a much better economic cost, as we had mentioned, compared to the other hospitals. So that should be an incentivization to most of us. So before I leave it open to discussion, as chairperson, it's my prerogative and my pleasure just to ask a couple of quick questions. So first one to Vikas, Dr. Vikas. The procedure that you mentioned, what was the preliminary ejection fraction, in the pacemaker-induced cardiomyopathy that you showed? 60 to 30. So how often do you see the frequency of such things happening? And you explain that as a prognosticating marker to most patients before you implant a pacemaker?
Yeah, of course. I told you almost 20% of patients we see, those who have pacemaker implanted to the right ventricular apex, 20% of them, they develop left ventricular dysfunction. So now it's our practice to discuss conduction system with all the potential pacemaker patients.
So you obviously have to explain it to the patient beforehand only that this is something which may potentially happen.
Of course.
Yeah.
Of course.
And his bundle pacing is much more economical than comparative pacing, as I understand. So is that something which is taking?
No, and all other centers, this his bundle, left bundle is much more expensive than the conventional system. Conventional right ventricular pacing.
Okay.
Holy Family, both are at the same price.
At the same price.
Charge extra for this extra effort.
Right. So, thank you. And Dr. Amitabh, the usual life of a pacemaker is approximately stated to be 10 to 12 years if I'm not wrong. So, Bluetooth and other things which are going to be incorporated, does that affect the life of a pacemaker or it is something similar that you see?
No, as I mentioned that this Bluetooth is a low energy technology that is used. So low energy Bluetooth device is there. And as far as because these devices are the latest generation devices, even the battery technology is improved. So in fact, the life expectancy of this type of pacemaker is much more than the non-Bluetooth, because the battery itself has also been upgraded, and the Bluetooth, the Bluetooth technology is very low energy. So battery life is actually not affected by the fact that you have remote control.
Right. And also since I would assume since all this thing is happening with the level of AI which is there, so all this data is stored in the cloud somewhere so that if you want to revisit that data or come back to it, you can anytime you can interrogate that data and come back at any point in time for any patient.
So usually we set the transmission interval to 1 month.
Yeah.
Every month the whole. So it's like what we do when your patient comes to us, the programmer in program checks everything and that's it. So automatically the data is set. So 1 month every patient the data is sent to the server. The people at the server, they see if there is any actionable data. Otherwise, that is stored. And anytime you have the whole history of the patient, so you can also the dashboard is available. Even the earlier data you can.
I hope that all the alarm signals are not focused on your phone, because otherwise then you will have no quality of life.
So that was a big challenge that was available, that was there with us. We are starting it, so the number of patients are not very high right now, but going forward, like in Western countries, there is separate dedicated team to look after these type of products. The company also helps us in this. That right now they are representative of screening, filtering out the data, and only the important alerts come to us. But subsequently, right now they are not charging anything extra.
Right.
But in Western countries, there are now systems where there are third parties who filter the data for you. They charge a little bit.
And lastly, do you have a thoracic surgeon in your team?
Yeah, we have Dr. Nitin is
Okay, he handles the thoracic.
He handles the thoracic part.
Thank you so much. So I will let it open for discussion at the
Sir,
floor.
please be seated. Dr. Tulsi is not happy that you are standing. He wants you to be seated. Friends, let's have a quick question answer session and finish it in next 15 minutes. And I think we can have all the relevant question answer session. So my first question is about the conduction system. We understand that his bundle pacing is the most physiological system of pacing. And sir also mentioned that there are other systems which have evolved but which are actually costlier. Sir, what is your experience of his bundle pacing in Holy Family Hospitals?
Thank you, sir. So, whether his bundle pacing or left bundle branch pacing, we now term it as a conduction system pacing. So, Holy Family Hospital, we are very fortunate and it's a privilege to inform you that it is one of the very few centers in the country who is offering conduction system pacing to all comers. So what is the practice in the country right now is, if somebody has a heart block and he goes to the hospital, the therapy offered is a conventional RV apex pacing. If you want to do a conduction system pacing, it costs you 1 lakh rupees more. But at our center, because of our efforts and because of the industry support, we offer this conduction system pacing to all patients at the same price. So we are one of those centers who are offering conduction system pacing to all comers. We have now largest data, which Dr. Vikas has presented multiple times in Asia Pacific Heart Rhythm Society, in American Heart Rhythm Society. So our data is now being even projected abroad in almost all international forums as one of the centers who is doing conduction system pacing for all comers. Thank you.
Sir, you presented some celebrities who died of sudden cardiac death. Puneet Rajkumar and the other celebrities. My very humble question is, could anything have been done to prevent those deaths?
So the one thing which could have been done was a prompt CPR. As we have seen the videos of KK, when he was doing his concert, he was in visible discomfort. Probably he was having a myocardial infarction. And a very common scenario that they are roaming around with this LV dysfunction. But nobody offers them therapy. Because this therapy is like insurance. Patient is going to tell you, why should I spend a 4 lakh rupees, 3.5 lakh rupees machine, then there are chances I might not require it. So we have to explain it to them that it is like buying a car insurance. You buy a car insurance with car, whether you are going to hit your car or not. So patients with heart failure are to be counseled in this manner, because this device is like an insurance. Because once you have that sudden cardiac arrest, nobody knows how to do the CPR. You will not make it. Thank you.
Sir, you mentioned about this bundle pacing, the most physiological way of pacing. But we have had the other type of pacemakers now. We have the Micra AV, which is a very small, very small kind of a device which can be implanted in one of the walls. What is the difference between doing, let's say, a Micra AV and doing his bundle pacing? What incremental benefit do we get by spending 14 lakh rupees over his bundle pacing?
So the answer is unpopular, but as far as the incremental benefit is concerned, Micra does not have any incremental benefit, because Micra is also again a RV apical pacing. So as far as the physiological aspect of pacing is concerned, Micra is as good as conventional pacemaker. Where Micra stands out is that you don't need to puncture the veins, so if your veins are not good, you can go through there. If your patient's general condition is so poor, old, that you don't want to go to quite an interventional opening up surgical procedure, then you can give Micra. But as far as physiological aspect of pacing is concerned, a conduction system pacing actually outclasses Micra AV.
Okay. Sir, you mentioned all the three talks were about more or less about pacing, about sudden cardiac death,
Yes.
about electrophysiology, inspired by Dr. Mohan Nair. God bless his soul, sir. I hope you are doing interventions also?
Yes.
PTCA also?
Yes, sir.
Sir, just a comment, sir. Because many people are asking, these people are not doing PTCA?
So that was the reason I showed this slide. So PTCA is the bread and butter of cardiologists. So we do all kinds of interventions. We do advanced all PTCA is like anything that you say, left main intervention, bifurcation, rotablation, IBL, lithotripsy, everything. So as far as the cardiology intervention is concerned, we do all kinds of interventions that is there possible under the roof. Pediatric cardiology is something which I would say we are a little behind, because we don't have a full-time pediatric cardiologist with us. We have a tie-up with SPOTS for the pediatric cardiology. But apart from pediatric cardiology, as far as the adult cardiology is concerned, we have done all procedures that are.
Sir, are you doing it 24/7? Do you have a PCI program?
We have 24/7 primary angioplasty program, which Dr. S Sengupta would be probably remembering when we started at Saket City Hospital, and before that we were at Max Hospital, Patparganj. I am proud to say for the last 20 years that I have been doing interventions, I have hardly thrombolized 4 or 5 patients.
Sir, whom to contact?
You can contact me. There is a helpline number also that is available. We will be sharing that number. It's a very simple number, 7867 000005.
You have an ambulance available, sir?
We have an ambulance available, but most of the time it is engaged by other. But if required, we can pick up patient from anywhere.
Sir, because none of the physician friends here would like to dare carry a patient of ACS in his own car.
Sir, we have been picking up patients on higher BP. We have been taking a patient off the floor, we have put ECMO at the peripheral sector and shifted the patient. I do not have time, otherwise I would have shown all these things. We have a ECMO system which is so portable that you just need a small, one person can carry that ECMO system and the patient can be transferred on a device.
Sir, Dr. Anil Gupta sir has a question.
Sir, in left shoulder branch spacing, how the right vertical is depolarized?
Yeah, see, in normal sinus rhythm also, the conduction system from the his bundle travels down to right and left both. No? His bundle divides into two, right and left. The right bundle carries the impulse towards the right, and the left bundle comes. So same way, he implant this left bundle pacemaker just close to his bundle. So it travels down, uses both the conduction.
So basically, a little part it goes retrogradely and goes into the right. Most of the time when we have these type of blocks, the blocks is prior to the division of the left bundle. So that's why
Retrograde and then.
Sir, Dr. P.K. Bangla sir has a question.
The question was same. Is the his bundle pacing and the left bundle pacing same?
So just to clarify, his bundle pacing started earlier and his bundle pacing attracted a lot of traction, but the problem with his bundle pacing is the thresholds are very high and the stability of the lead is not that great. Because his bundle, where we are supposed to put the lead, it is a very fibrous area and the target that needs to be achieved is a very small target. So you have to be very precise where the lead is put, and since it's a fibrous area, the dislodgement of the lead is possible. So his bundle pacing is almost abandoned all over the world. Most of the time the thing is left bundle pacing, you are putting it in the muscular septum, the lead do not get dislodged, and even patients who are pacemaker dependent. So the challenge was patients who are pacemaker dependent. If you put a his bundle and suppose tomorrow the threshold suddenly becomes very high or the lead gets dislodged, patient is dependent on the pacemaker, patient will have a problem. So with left bundle pacing, the confidence level is so high that now we are doing left bundle pacing even in patients who are pacemaker dependent, because we are sure that we will be able to achieve a long-lasting pacing in these patients.
And the right ventricle is depolarized, retrograde.
No, it is repolarized to the same. So basically, left bundle pacing is not that you are pacing at the end of the you are pacing right and then divides into the left bundle and the right bundle after the his. So when as soon as it enters the muscular septum, there you are pacing it. So the whole thing is connected to each other. So they
Another thing I want, it's very common to have ejection fraction of 35%, 40%, 25%. I have hardly seen that these patients are having ICD or AICD. How difficult it is to convince these patients to have AICD.
Sir,
they are having normal life and
exactly.
at times, person with 25% ejection fraction has a better exercise tolerance than somebody having 40%. So how often and what percentage of such low ejection fraction patients are having AICD?
Sir, what you are saying is absolutely right, and as Dr. Mohit said, that risk of sudden cardiac death in fact is much more in patients who are not vaccinated. Class 2, class 3, the benefit of putting an ICD is more in patients who are class 2 or class 3. Because if they die, they will die because of sudden cardiac death rather than from failure. So how we really convince these patients is, obviously India is a cost-sensitive country, so
how much does it cost?
sir, a single chamber pacemaker ICD in our hospital is around 4.5 lakh the device and 70,000 rupees the implantation. About 5 lakhs. So we tell them, as Dr. Mohit said, it's like buying an insurance.
How often are you able to convince in your hospital?
Sir, in our hospital, we do almost 10-12 implants in a month. So most of our patients actually, maybe they are pre-selected or whatever. Fortunately, touch wood, we are able to convince them. CIEDS नहीं है, we don't have CIEDS.
Dr. Amitabh, we have a very eminent pediatrician here, Dr. Ashok Chakravarti.
जी sir.
He practices in Saket, literally the king of pediatrics in Delhi. He has a very relevant question to you, sir.
जी sir.
Good evening, Dr. Khan. Though we don't see too many cases of any cardiac problems in our day-to-day practice except VSDs and ASDs, but once in a while there is a thing called constructive hypertrophic myopathy, which is a congenital problem and turns into families. Have you some experience about that and how do you go about managing?
We have so many patients of hypertrophic cardiomyopathy, obstructive as well as non-obstructive. In fact, one of the treatment of an HOCM is putting a pacemaker.
Okay.
Because putting a pacemaker in that situation, in fact, the fact that synchronicity happened when you put a pacemaker, it is beneficial in a HOCM patient.
Okay.
So what happens is, in HOCM when the heart contracts, the septum and the wall come closer. So what you do is you start pacing. The septum will contract first, the ventricle will contract later.
Okay.
So this makes the outflow gradient better. So one of the treatment is pacing, and then obviously there are other treatments. We also do septal ablation. So what you do is you identify the septal artery, you put alcohol in that, you create an MI. So what happens is that septum which was bulging into the left ventricle which was causing the HOCM, that gets infarcted and you get so we are doing all kinds of things.
So once in a while it is a case we can represent with very great confidence.
Sure.
Thank you so much. Thank you so much, and you are doing a great job, Holy Family. One thing which Dr. was about to say, out of all the corporate hospitals, I must tell you my personal experience. I took my mother-in-law to Holy Family long time back. It is the most compassionate hospital. Of course, there are others also, but reasonable treatment at a very reasonable cost. And being a missionary hospital, we have known you for ages. Patna, Holy Family Hospital, Delhi, Holy Family. You have the zeal to work with passion, without looking at the balances. Thank you so much, the team Holy Family. God bless you all.
Sir, we hope to continue the tradition.
Thank you so much, sir. Honored to have you here.
I'm sure, any questions from here? Any questions from here? No. Dr. JPS Puchu, sir. Sir, be careful, sir.
Boss, okay, boss.
Be ready for PG question.
Revise your DM question.
Be big boss.
No DM questions, sir. So those were some nice talks from Dr. Mohit, Dr. Vikas, and we know Dr. Amitabh. We have met before. So Dr. Mohit, you talked about sudden cardiac death. So CIEDS is the most common cause of sudden cardiac death, accounting to at least 80% of all cases after the age of 35. What about the age below 35? Genetic channelopathies and probably cardiomyopathies account for the rest 20% of sudden cardiac death. Your words on that?
Yes, sir. I totally agree with the statement. In young patients, of course, these days because smoking is very prevalent in our society, and also because many patients have a strong family history of CAD around, a lot of stress also. We get young myocardial infarctions as well. But as far as majority is concerned, I agree with your statement. In young patients, it is usually some channelopathy, some cardiomyopathy, a post-myocarditis sequelae, and these patients form majority of the patients who have sudden cardiac arrest and require AICD.
So, Dr. Mohit, talking about the terminal rhythm, is the ventricular fibrillation or the pulseless ventricular tachycardia. So, that's the end of the life rhythm. So, what about the agonal rhythm, which occurs shortly before death, and death is imminent then? The agonal rhythm.
Yes, sir. So it happens like that only, as you have rightly mentioned. So in this channelopathy or cardiomyopathy, there comes a trigger in form of agonal rhythm or a ill-placed ectopic, and it, as I said in my talk, it starts riding the horse. So there the ventricular tachycardia starts and it becomes a hemodynamically significant ventricular tachycardia or degenerates into ventricular fibrillation and we lose the patient.
So this agonal rhythm is not from the heart. This is from the brain stem, which stimulates, sends signals to the heart to beat. So this is the end of the life, agonal rhythm. So talking about the treatment, as you said, CPR and defibrillations, medications, ECMO, percutaneous LVDs, and as an alternative to ECMO, ICDs, coronary angioplasties, catheter ablation, especially in atrial fibrillation and VT. See, if you have a prior scar from an MI, you need to ablate that, which would prevent, at least 45% of recurrent VTs. I'm talking about the post-sudden cardiac death trial.
Right, sir.
Okay, sir. Let's go ahead and talk about the cardiac screening, which is recommended after the age of, what would you say, 14 years?
So cardiac screening for ASCVD, I would still say that you have to wait for at least 25-30 years. But
I'm talking about family history of sudden cardiac death.
So these patients, some guidelines say up to 14 years, some guidelines are now saying even up to 12 years. You have to start screening them.
Okay. My last question to you would be regarding shockable versus non-shockable or ashockable rhythms. So ventricular fibrillations, ventricular tachycardias are shockable rhythms.
Yes.
And what about ashockable rhythms? So where the defibrillator doesn't tell you to shock it. So these would be what? Asystolia and PEA.
Yes.
Right, sir?
Yes.
Wonderful, sir. And our last question to you would be regarding medication. Would you prefer to give Amitabh if there are 3 shocks given and not successful? 300 milligram IV Amitabh given.
Yeah, 300 milligram IV Amitabh given.
If 3 shocks does not defibrillate the patient.
Yes.
And do you use adrenaline, IV adrenaline anymore?
Yes, we do it. We in the ACLS protocol, cardiac we use the IV.
I've never had any success with adrenaline. Anyway, sir. Okay, regarding the devices. So pacemakers, ICDs, and the CRTs. So heart failure with atrial fibrillation, ablation significantly reduces mortality. What do you say, sir?
Yeah, I completely agree. Heart failure patients who get atrial fibrillation can suddenly decompensate slowly.
So Dr. Vikas talked us regarding the MCS, which are the mechanical circulatory support systems today. Are we now ahead of times, which was earlier? IVAP, ECMO, tandem heart, Impella, LVAP. So we have advanced, but still now, they need open heart surgeries. So what is the future of these MCS? The future of MCS?
MCS is something that needs to be initiated very early. Unfortunately, most of these MCS are very costly. At our hospital, we have the ECMO and we have used ECMO in a couple of patients. We have used Impella also. Impella would cost around 20 lakh rupees. And in a sick patient where the outcomes are not really guaranteed, to commit to a patient for an Impella for 20 lakh rupees and then subsequently he would require some kind of an intervention. So it requires a lot of economical strength on the part of the patient to do this thing. Although scientifically speaking, mechanical circulatory support, in fact, in patient with cardiac shock with MI, now the technique is to stabilize and then intervene. Pehle it was straight away taking the catheter. Now the thing is, MCS is available to us. First decompress the LV and then take up for the LV. But then in our country, finance is a challenge, so that's something that we have.
So Dr. Amitabh, because of the scarcity of time, my last question to you, what is the future of the pacemaker? What do you have to say about the bionic pacemaker? Heart pacing with real-time modulation designed to synchronize heartbeat with the breathing.
I believe the technology is improving tremendously. You have this Micra, then you have this Micra AV, and then there are now technologies that are available where you have it small kind of a transducer into the LV, and there is an outside stimulator, there are subcutaneous ICTs, and future, is always bright, sky is the limit. So as far as bionic, all these technologies, they are coming, AIs are coming up, you have a Neuralink chip test, Elon Musk has put. So,
my last question regarding the CCM.
CCM is also a very good technology that we have available in our country. We have not had experience personally, but in patients who are not candidates for CRT, CCM is one technology that they do.
So only reserved for NYHA class 3 and with an ejection fraction of 25 to 40%. Thank you, sir.
Sir, I'm the last person. Thanks for very wonderful talk and exhaustive question answer. Dr. Tulsi had introduced a term diagonal rhythm, which we hardly see. And I'm introducing another term, commercial cordis. Have you ever seen such case?
Commercial cordis is basically when you have a direct impact on the heart, and that causes anything.
More likely sports person.
Most likely in sports person, so
Hello.
Especially in athletes, you must have seen patients who are footballers. They suddenly they have an impact and then they fall down. So there are two things that can happen. One is direct injury to the coronary arteries. LED is since anteriorly injury to the LED is common. More frequently it is what Dr. Mohit said, arrhythmia, because the impact is at the time where there are T waves. So it's an R on T phenomenon. So with an R on T phenomenon, the patient goes into ventricular fibrillation. So these patients, it is very important to have IC defibrillators available in stadiums, available in gyms. That's also one important aspect that should be considered. And in fact, I would encourage forums like you to spread this message that AEDs gyms should be available in public places because they are very important. Once they are available, people will learn how to use it.
Thank you, sir.
Very good.
Thank you.
Friends, we had a wonderful session with three wonderful cardiologists from Holy Family Hospital. It's my duty to ask Dr. S Sengupta, our wonderful moderator, to just summarize this in 1 minute.
Thank you. We have had three extremely fascinating discussions and presentations from Holy Family, and they have rightly put into perspective the amount of technology which can help you out, but nothing comes in in between compassionate patient care and individual doctor to patient relationship, which they have very amply exemplified, and also the fact that they are doing every possible procedure as Dr. Amitabh mentioned, which is a fantastic thing. So I hope that we carry this message forward, and it's been a wonderful evening. Thank you very much.
Thank you. I would request Jaya to come here. Jaya to come here, and I would request all the three wonderful cardiologists to come here.